It's an emerging field, I believe, that is changing the landscape in the treatment of metastatic breast cancer. Specifically, you have now the opportunity to candidate many more patients to CDK4/6 inhibitors rather than to chemotherapy. So if you have visceral disease and you have an ER-positive disease, it's no more opportune to propose a chemotherapy, because we clearly listen from the data from the MONALEESA-2 and also from data of PALOMA-1 and PALOMA-2 that a CDK4/6 inhibitor in combination with an endocrine therapy can increase progression-free survival with a dramatic benefit for patients in terms of clinical benefit rate and with a very low toxicity. So I am quite sure that for the future we will have less patients receiving chemotherapy. This is an important topic, I am quite sure. Precision medicine is not ready for prime time, because for some disease, of course, you have a target, specific target that is designed for a drug. For breast cancer, you have very few targets. One of these is estrogen receptor, and it's quite clear that if you combine an endocrine therapy with a CDK4/6 inhibitor, you have a dramatic benefit. Another target is CRB2, and we know very well the history of pertuzumab and trastuzumab. Unfortunately, for triple-negative breast cancer, we don't have still no targets. I believe the results are outstanding. They replicate exactly the same results of the PALOMA-2 trial. I am quite sure that there is a reporting of toxicity that is a slight more respect to the PALOMA-2 in terms of infections, let's say. It's well reported in the New England. It's quite surprising that EMA, the European Medicines Agency, decided to reject the accelerated approval for ribociclib. First of all, we can wait for the abemaciclib data. Yesterday we listened about a neo-adjuvant trial with a dramatic effect on Ki-67. I believe the future of CDK4/6 inhibitors is in the adjuvant setting. There is a post-neo-adjuvant setting ongoing of the German breast group, and if the results will be positive, we have the rationale to move in the adjuvant setting in ER-positive breast cancer. It's quite a little bit different because PD-1 inhibitors are more toxic, and it's quite unusual to deliver a PD-1 inhibitor for 1 year in the adjuvant setting. It's more usual, I believe, to deliver a CDK4/6. We have many patients in the metastatic setting receiving a CDK4/6 for more than 1 year. I believe we will have very interesting trials in the HER2 population. We have actually running 2 trials. One with the dual blockade, pertuzumab, trastuzumab, endocrine therapy, and palbociclib, and another one with trastuzumab plus palbociclib plus endocrine therapy. So maybe also we will have effect in HER2 population in the neoadjuvant setting. So my conclusion is that CDK4/6 inhibitors changed the landscape in ER-positive metastatic breast cancer. They should be considered the first-line treatment in these patients. If they are progressing, you have also a study in the second line that is the PALOMA-3, so we have also a second line. We should explore for the future, I believe, mechanisms of resistance to CDK4/6 and maybe having new trials combining CDK4/6 with other agents like PI3 kinase inhibitors.